Dr. Giampaolo, thank you for the opportunity of speaking to you on an important topic like multiple sclerosis. What is multiple sclerosis?
Thank you. First of all, thank you very much for asking me to speak to you. Multiple sclerosis is an autoimmune disorder. In other words, your body's own immune system has been triggered, and we're not too sure what the trigger is, to attack the lining around the nerve fibers in the brain. The fatty layers that exist around the nerve fibers are responsible for your nerve conduction along the nerve fibers being very speedy, and that gets attacked in the central nervous system, which is your brain and spinal cord, and not the myelin in your peripheral nervous system. So it's a central nervous system problem, and the myelin and actual nerve fibers get destroyed in little attacks that occur, and some of them repair themselves, some not adequately. And over time, this can result in neurological deficits and slow progression of neurological disease, especially in the past. But that's changed, and there are a lot of medicines available now to treat the condition.
Dominique, what symptoms will lead to me considering the possibility of MS? When must I start worrying?
So, I think obviously it can attack the brain and spinal cord at any level and present with a whole lot of symptoms. But the most common neurological presentations are usually an inflammation of your optic nerve to your eye, so the development of pain behind the eye together with blurry vision that persists for longer than a day or two requires you to go and have that investigated. Numb patches that persist on your body for a period of time, weakness in a limb. But these all carry on for a few days. It's not something that appears for a minute and then disappears, or an hour and disappears. It's usually a persistent neurological symptom that can involve limbs, eyes, and persists for a day or two, and then you should go to the doctor and have that examined.
So how does it differ from, say, having a vascular stroke?
Not much difference. A stroke is usually sudden onset. This might develop over a day or two. Strokes are usually a cataclysmic event that occurs at the time, and suddenly your arm and leg feels weak and you can't talk. And strokes normally involve the grey matter of the brain, and therefore features like speech, etc., are affected, whereas with the white matter being involved, it's more power and not eloquent symptoms that develop that would occur with a stroke.
So if I consider the possibility of MS as a patient, how do I get it diagnosed?
So I think you'd first go to your general practitioner and ask him to examine you and mention your neurological symptoms, and then hopefully your general practitioner has MS in the backs of his mind and decides will then just refer you to his local neurologist. Sometimes this is missed. A lot of patients are treated for fatigue and are diagnosed with fibromyalgia and general body pains, and the penny doesn't drop that the patient might have multiple sclerosis. And so I think if you get persistent neurological symptoms and you're not happy with what your general practitioner is saying, either change your general practitioner or seek the help of a neurologist who will then do a scan and a lumbar puncture in order to make the diagnosis.
The problem with MS is that symptoms, as you say, can improve and resolve and then get more pronounced, or you have a relapse.
And the longer the diagnosis takes to be made, and the symptoms will get better, and then the patient will ignore them and only wait for the second symptom. So you also require your general practitioner to be alert to the fact that it could be MS.
Previously, when we had a patient with acute onset or aggravation of his symptoms, we basically just had steroids for the treatment of MS to suppress the autoimmune reaction. But there are a lot more newer drugs available.
When I started off practicing as a neurologist, which wasn't that long ago, all you wouldn't even tell the patient the diagnosis. It would be a hushed diagnosis in the corridor with your colleagues, because there was not much that you could do for the patient. So because it was an autoimmune reaction, in order to switch your immune system off and allow some nerve recovery, we give high-dose cortisone. But all that does is it treat the attack at the time. It doesn't help with your long-term prognosis or preventing the disease from occurring, even if you give recurrent doses of cortisone. So cortisone was the initial treatment just for the acute attack, in order for the patient to improve quickly. Then there was an advent of a whole bunch of medicines that we call disease-modifying therapies. They're not cures, but they modify your disease so that you can have a normal lifespan and not accumulate a lot of neurological deficit over time. And initially there was just a handful of them, interferons, etc. Now there must be at least 15 drugs on the market. And how the drug gets chosen is governed a little bit about cost. And we've got a certain guideline that we write up, and there's a tiered approach to what medications to use. So we're almost spoiled for choice, and in most patients we can almost guarantee them a normal life. They just have to be on a medicine, either an injection or an oral tablet, depending on what medicine is chosen for the patient, depending on their age, reproductive ability, how severe their illness is.
Dominique, is there a place for bone marrow transplant?
It's still considered to be fringe therapy, so in other words, not standard platform therapy for multiple sclerosis. Because it's an autoimmune condition, once you've tried most of our medicines that we have got, and we're still getting relapses in those very aggressive cases, and our back's up against the wall, something called an autologous hematopoietic stem cell can be done. That's used for lymphomas and leukemias, in which you can take off the hematological stem cells out of the bone marrow and give a patient a high dose of chemotherapy to completely try to suppress their immune system, almost like rebooting the immune system, and get rid of the memory B cells that have got the capacity to pick your own brain out as being abnormal. And once we've got rid of those, you can give the stem cells back, remake your immune system, and it's almost like a virgin immune system that won't attack you anymore. So it is the last resort. There is a 0.1% chance of dying during the procedure. So as you know, we take a Hippocratic oath to do no harm. So the bottom line is it's always the last resort and not something that should be just jumped into. Very effective, but not a cure.
Dominique, if I diagnose a patient today with MS, what's the message that I must give that patient?
The first thought for the patient is, I'm going to end up in a wheelchair, and I can give a talk at a patient MS congress with over 300 people there. There won't be one person in a wheelchair. So the message you give to the patient is, get on medicine early, take your medicine regularly, be compliant, and have a normal life.
Thank you, Dominique. I think that is the most important message, that MS is not a disease without hope. There is a way to treat it and to manage it. Thank you.